Alright, so in the diagnosis of an MI, you're going to use this no matter what. Necrotic myocytes leak intracellular molecules such as troponin T, troponin I, troponin C that are part of this sarcomere complex seen here in this image. Now, don't forget that we leak out everything. This means that we also leak out lactate dehydrogenase and creatine kinase and B. So this is the point where you need to really listen up and focus in. The most important markers you need to know are the proteins that are specific for the heart. Which are these? Troponin I, troponin T. The type of troponin I in cardiac tissue is completely different from the troponin I in skeletal muscle. After there's ischemia, it takes a while for the intracellular contents to actually leak from the cells. This is why the electrocardiogram is the gold standard for the first 6 hours. Now, watch out for ST elevation or depression, peaked or inverted T waves, a new left bundle branch block, pathologic Q waves, or poor R wave progression. I previously included the electrophysiology behind these findings, but it takes way too long and it's not worth your time. Most of these questions will describe some of these findings or show you something very simple, such as ST, depression, or elevation. Now, troponin I will be elevated after 4 hours, and it sticks around for approximately 7 to 10 days. So here's our image. Now, troponin I peaks around 2 to 4 hours, usually 4. It is highly sensitive and specific. This means that you won't have any false negatives or false positives. Now, what about this guy, CKMB? So the MB part just tells us about the two components, which are M and B. All tissues need creatine kinase. The combination of an M or B helps us figure out where it came from. For example, CKBB is a homodimer found in the brain. Unfortunately for us, CKMB is not unique to cardiac muscle. It is also present in skeletal muscle. So checking for this marker is highly non-specific, meaning that we have a high probability of false positives. So CKMB also begins to rise within this 2 to 4 hour period because it was also liberated from within the myocytes at the same time as the troponins. But it peaks much later, at 24 hours, with a pretty serious drop around 48 to 72 hours. It's almost gone. This means that in the early onset of someone having chest pain, you're going to pull both of these markers out of the person's blood. If they really suffered an MI, both of these markers are going to be elevated. So why do we care about CKMB if troponin I is more specific than any other protein marker? The only useful thing about CKMB is that you can confirm someone had an MI and also use it to determine if the patient had another MI since they were admitted to the hospital. If you see a peak of CKMB again after 48 hours, you need to be really careful and suspect that your patient may have suffered another MI. Why can't we check troponin I? Look at the graph. Troponin I plateaus. It stays rather elevated. Remember, 7 to 10 days, right? Because this cardiac marker stays elevated for up to 10 days, it takes much longer to eliminate troponin I from the circulation. All right, let's keep going. During what period of time after a myocardial infarction is there the greatest risk for ventricular pseudoaneurysm formation? So you have to remember the time frame for both pseudoaneurysm and a true aneurysm. Remember, they are completely different in time and structure. A pseudoaneurysm forms when the infarction takes out a large part of the wall and the only thing left is one layer of fibrous adhesions of the pericardium holding in all of that blood. On the other hand, a true aneurysm is dilation of scar tissue after everything has healed. This is all 3 layers of scarred cardiac wall tissue. And this occurs much later on in the post-MI period. So the answer is 3 to 14 days after myocardial infarction for pseudoaneurysm, and after 2 weeks for a true aneurysm. All right, here we go with the flash quiz. Describe the time period of CKMB elevation after an acute myocardial infarction. When you think about cardiac markers, always remember that troponin I is the most specific, so any questions about CK&B should make you think that they're asking you about reinfarction. So here's the answer. CK&B peaks at 1 day after a myocardial infarction, and it's absent by day 3 unless there's reinfarction. This is super important. It's a helpful tool in trying to determine if your patient suffered another infarction.